Give a little plug for our walk that is coming up on June 3rd in Salt Lake City. Registration begins at 8 a.m. at Liberty Park, and the walk begins at 9. We will be celebrating the 25th anniversary of the Rocky Mountain chapter, as well as our regular walk activities. It'd be a special time, it being 25 years. Would love to have any of you, I know some of you are far away, but anyone join. You can go on the website, make a group, or just come that day. And even if the $35 registration fee is a barrier, we don't want that to be. Just come and celebrate with us. Okay. It is my pleasure to introduce Dr. Tracy Frech, who is an associate professor in rheumatology and immunology at Vanderbilt University and director of the Scleroderma Clinic, and which is a designated scleroderma research and treatment center by the National Scleroderma Foundation. Prior to joining the faculty at Vanderbilt, Dr. Frech was an associate professor in the Department of Rheumatology and directed the Scleroderma Clinic at the University of Utah for over 15 years. As one of the world's leading scleroderma researchers and clinicians, she presents nationally and internationally to both professionals and patients. So I'm very fortunate to have her here today. And I will just tell you from a personal level, she is my doctor, and I had very scary progressing scleroderma that she was able to stabilize, and did so in the most kindest and caring and compassionate care that a doctor can give. I don't want to say anything else, else I might get emotional, but she is truly one of the best researchers, doctors, and humans that I've ever met. So here is Dr. Tracy Frech.
Thank you so much. And I'll try not to get emotional either, because it is truly my honor and privilege to be here and to see many faces that have been my work family over the years. And I just want to start by thanking you all for being here. I know you're taking time away from your busy weekend, Mother's Day weekend at that, to spend time today. And what I really want to do is try to explain why understanding Raynauds phenomenon is so important, and how we can move the field forward, and how I truly do believe there will be subsets of cure for this disease in the near future. And so I hope to present the research that I have done with your help and getting to that conclusion. I have no relevant financial or conflicts of interest. Anytime I do any consulting, all the money goes directly to the National Scleroderma Foundation, and I think that's really important. So I'll mention pharmaceutical products and things that we use for Raynauds. I don't receive any money from any companies. So I had really 3 objectives today, and I wanted to cover why Raynauds, or understanding Raynauds, is so important, how we monitor and longitudinally assess Raynauds, and really highlight the value of many providers working together, both for patient management and for research to try to move the field forward. And the last 2 parts of this really are to give a shout out to all the patients that have filled out questionnaires and involve themselves in research, particularly those that involve skin biopsies. Each of those samples have been analyzed, and each of those samples have allowed us as a community to work forward towards a cure. So I thought I would start with a question, and we don't have to answer this out loud, but in your mind, one of the questions that come up, well, what's the most common first disease manifestation of scleroderma? Would that be Raynauds phenomenon, interstitial lung disease, or pulmonary arterial hypertension? And the pictures here to show that we diagnose interstitial lung disease with high resolution CT, and some of you out there might have had a CT, showed some scarring, and it led to a diagnosis of scleroderma. And pulmonary arterial hypertension can sometimes be caught on echocardiogram done for another reason. And this is a bit of a trick question, because oftentimes when we're talking about scleroderma, particularly for research purposes, we say, what was your first non-Raynauds phenomenon manifestation of disease? And the reason that gets confusing, I think, in the literature when we're trying to read about scleroderma is for some people, Raynauds and their first disease manifestation of scleroderma will occur right in the same month or a short time frame. There will be other people that will have Raynauds for many, many years. And then all of a sudden their hands get puffy, or there's a shortness of breath episode and the diagnosis is made. And the whole reason this sort of concept of Raynauds being the first potential disease manifestation is important is it allows us to try to understand treatments and how to be more proactive in preventing complications of disease. So I like, many people have probably seen this slide before. I love kind of starting with how we define scleroderma, because I think that takes out a lot of the confusion when you're on the internet or you're reading to sort of say, you know, do I have scleroderma, and how do doctors make this diagnosis, and how do we put this disease into subcategories? So I like to start by saying, you know, really we lump a lot of different diagnoses into the term of scleroderma. So scleroderma is Greek for hard skin. And we think about the first branching of scleroderma as, is this localized to skin only? So is there an absence of disease, internal organ manifestations? Or is this systemic scleroderma, where we need to think about or understand the inside of the body as well as looking at the skin? And I point this out can be kind of tricky, because that ANA test, or that blood test that may lead you to a rheumatologist, can be positive in both skin-only scleroderma and systemic scleroderma. But what's the really kind of branching point is the presence of Raynauds in systemic scleroderma. And that's really an important clue, I believe, in not only making the diagnosis and thinking through how we want to be preventative and how we want to treat. And the reason that becomes super important is the next kind of decision-making point most doctors will need to do is say, okay, if I believe this patient has systemic scleroderma or systemic sclerosis, is their disease limited? And that means, is their disease below the elbows, knees, with no abdominal, upper arms, or thigh involvement? Is this diffuse, meaning there's involvement in the upper arms, thighs, or belly? Or is this systemic sclerosis without any hard skin, meaning there's no skin involvement? And the reason this is really tricky, particularly for patients, is you can change over the course of a few years. You can start as limited, so you've entered a research study as a limited systemic sclerosis patient, and then suddenly you can become diffuse, or vice versa. You can have diffuse skin involvement. We use treatments, the skin gets better, or you can have some atypical presentations, and this is common in clinic. Patients will have a lot of chest involvement, and that in particular, if you're doing the skin score, if it goes below the clavicles, it's considered diffuse in some studies, and others, the chest involvement is discarded if it's just on the neck. And you can see those are kind of arbitrary definitions, and it doesn't help you as a patient to sort of say, well, this is where your skin is at. Where it's really helpful is to try to understand what do we think the disease course will be moving forward. So what we more commonly do is use that ANA. So the ANA is that screening test, and then we subset all these autoantibodies. And we say, okay, if you have an SCL70 or a topoisomerase antibody, those patients more commonly have diffuse skin involvement, but they can have overlap with other conditions, and they can have limited disease. But what it tells us when we have that autoantibody, as a physician, what do I need to make sure I'm paying attention to? And in the case of that autoantibody, we really want to look for interstitial lung disease in that subset of patients. Now, I'm not going to go through all of the different autoantibodies, but this is to kind of highlight, as you're trying to think through your diagnosis of systemic sclerosis, it becomes incredibly important to ask your physician, where is my skin at today? And that usually is determined by the modified Rodnan skin score. That's really important in the first 5 years disease, becomes less important as the disease progresses because it stabilizes. And I'm going to show you a slide on that. And what is my autoantibody? But the take-home message really is, what a rheumatologist is doing is a patient that comes with Raynauds, we're thinking through the diagnosis of systemic sclerosis, and then we want to engage our subspecialists team appropriately so that we're maximizing our treatment for each part of inside of scleroderma. So I oftentimes say rheumatologists are really good at skin and muscles and joints, but we oftentimes need help from our other subspecialists to get you the maximum treatment for the other disease manifestations. So how do we do that? We start by saying, okay, in a patient that doesn't have Raynauds, doesn't have interstitial lung disease, and doesn't have pulmonary hypertension and has skin involvement, we really can be pretty good about that, skin-only treatment, working closely with dermatologists. But for Raynaud's phenomenon patients that have a new diagnosis of scleroderma, we really want to be on top of that. So the way we're on top of that is trying to say, in the absence of diagnostic criteria, using our classification criteria to say, does this patient have scleroderma? So what the physician does, the very first visit that you come, they assess where your skin is at, they look at your hands, and what we're looking for is telangiectasias and these lesions on the fingers. If there's scarring, those are called tips, pitting scars on the fingertip. And if there's actual ulcers, we diagnose those as vascular ulcers. So after we do this skin score, and what we're basically determining when we pinch the skin, is it normal, is it mild, is it moderate, or is severely involved? Where is the skin involved? How severe is the skin? And is there this presence of these different vascular lesions? And what I like to do is say, classification criteria, adding up points, that doesn't really communicate well to a patient what we're looking for. I like to show this as a Venn diagram to sort of say, when we're talking about scleroderma, we're always saying there's a vasculopathy related to immune dysfunction. So the immune system's really causing or propagating this vasculopathy. And then there's resultant fibrosis or scarring. So before this classification criteria in 2013, and I'm old enough that we used the kind of old ACR criteria when we first started our scleroderma clinic. We used to diagnose scleroderma only with scleroderma-specific autoantibodies, skin thickening, and interstitial lung disease. And as a community, I was part of this guideline development. We said we really need to understand the vascular manifestations of disease. And those, again, are listed here from the classification criteria. And so you might say, well, why was there this shift? Why did we think differently? And the reason is we really wanted to start focusing on early disease where there was a lot of disease activity, rather than just sort of trying to make a diagnosis late in disease where there was fibrosis or scarring that became somewhat obvious. And the reason for that is scleroderma is this progressive small vessel vasculopathy that leads to a dysregulation of your immune system. And the immune system's trying to respond to that vascular damage and lays down this scar tissue. So wouldn't it be important to get our patients early diagnosed when we're seeing the Raynauds and they have enough to suggest there's disease, and then really try to treat patients aggressively at that point and restore vascular health? And that really is sort of the kind of crux of a clinical assessment, is we have to actively screen for vascular and fibrotic. Again, that's a fancy word for scarring of the skin and the internal organs every visit, in that context of how long has this patient had systemic sclerosis. And if we can do this well, we can do this effectively, we can improve outcomes. And you may have seen this article. I give this to all my fellows. It's this Lancet article review of my mentor. He's in London, and he was really pivotal for getting me involved in the field of scleroderma and teaching me how to treat and monitor scleroderma well. And he wrote this really nice article that sort of talked about screening in scleroderma. So it was written for sort of generalists and saying any patient with systemic sclerosis, we need to be actively screening our patients for disease. Now, this is a Raynauds talk. So what I'm really going to point out is that there's a lot of vascular screening that occurs, and we can get important information from that vascular screening. So we do a vascular screen with a Doppler echo once a year. And then also those annual pulmonary function tests that we do, we measure something called a diffusion capacity. And both of these are looking for vascular involvement in scleroderma. And then there's all sorts of algorithms we can use. And one is the detect that even if those studies are normal, if you have a high index of suspicion for pulmonary hypertension, you refer to the right heart catheterization to make a diagnosis. And so one of the things that came out of this kind of proactive screening for pulmonary hypertension is we were catching patients earlier. And what was super interesting about this is once patients were on treatment for pulmonary hypertension, if it was diagnosed, their Raynauds melted away, got better. And as a physician, not only did their Raynauds get better, but we tended to see a lot of other subtle improvements with well-being, with sleep, all these other manifestations or symptoms got better with an aggressive vascular approach. So that was pretty exciting because if you think about it, as we were previously thinking about scleroderma, we were really trying to target fibrosis or scarring, and we were trying to understand the immune system. And I'm going to speak in a second of the challenges of that. I also I know this is a Raynauds talk, but I really like to remind people, if particularly you have that anti-RNA polymerase III antibody, blood pressure monitoring is an active vascular screen. And so checking your blood pressure and knowing where it runs is important. And this becomes even more important if you're on prednisone or if you've had reduction in your kidney function. Another thing I like to highlight here when we talk about pulmonary hypertension, one of the things that I've really been developing more at Vanderbilt, I had a bit of a struggle trying to do this at the University of Utah, is we get these echocardiograms. We're screening for pulmonary hypertension. We're trying to make it the early diagnosis and get early vascular therapy. Well, when the echocardiogram does not show pulmonary hypertension, but has some subtle abnormalities, what do we do with that? How can we treat our patients more effectively? And so we have been doing a lot more in trying to understand the role of cardiac MRI or primary cardiac involvement. And so this is kind of a long-winded, talk for saying, know what the screening is in scleroderma, because I think it's important, and then try to make sure your screening is up to date and that your doctor is talking to you about what they're going to do with abnormal findings. And in particular, make sure that you have your records of your echocardiogram and your pulmonary function tests annually. If you have a little folder, you can keep that for you and bring it to each visit and try to understand if there's been changes there. So why do I say that's important? Because we think when we talk about the term vascular disease, we usually are thinking about atherosclerosis as doctors. So what that means is, so you have these blood vessel lining cells, these are called endothelial cells. And over time, as we age, as we eat fatty diets or we're not exercising, we develop atherosclerosis, so that we get these plaques that occur in our endothelial cells. And we call it peripheral vascular disease when it's in the legs and coronary artery disease when it's in the coronary arteries. And that's usually how we think about vascular disease. And we, of course, want to be normal. So healthy diet and exercise really are the goal of long-term healthy diet and exercise is to keep your blood vessels happy and healthy. Well, the issue with scleroderma when we talk about vascular disease is it's really occurring in a different part of the vascular system. So when we do contrast studies or we do, look for vascular disease, we're usually looking at these big vessels. And in fact, pulmonary arterial hypertension is occurring in the pulmonary artery. Those are bigger blood vessels. And so our monitoring studies are pretty effective. Either your echocardiogram or the right heart cath, we have really good tools to assess these big blood vessels in our body. But what about scleroderma vasculopathy, which is occurring in that smallest blood vessel in the body, the endothelial cells, these capillaries, that we don't have really good assessment tools to assess that longitudinally over time? And in fact, when you use the term vasculopathy, all that means, anything with opathy is an abnormality. All we're saying is there is an abnormality of your blood vessel that's not inflammatory. Vasculitis is inflammatory, and we can rarely have an overlap. So you can have collagen vascular vasculitis and scleroderma, but that's really more rare. For scleroderma per se, there's not inflammation, there's vascular change that's occurring at that smallest blood vessel level. So how do we assess that, and how do we do a good job? Well, rheumatologists, I always think it's an honor to be a rheumatologist because we have the first opportunity to recognize this disease and treat patients effectively. So if you have a patient that comes in with Raynaud's phenomenon, puffy hands with fibrotic changes in the fingers and hands, this ANA with a scleroderma specific autoantibody, and capillaroscopy changes, you have a diagnosis of scleroderma. So we make that diagnosis. And you could see if it was quite subtle and it was puffy hands, this patient might be mislabeled as rheumatoid arthritis, or might be, say that they're retaining salt and not being taken seriously. And this happens with a lot of patients. They say it took so long to get me diagnosed. But where really I became kind of enamored with trying to move the field forward was in this field of capillaroscopy. So just by looking at the finger, you could make a diagnosis of scleroderma antibody pattern. So why this was so important is when I took one of my earliest studies, I took patients that had this early diagnosis. So they met criteria for scleroderma, and I looked in their blood to look for markers of inflammation. And what we see here is that patients clinically that looked exactly the same and met criteria for scleroderma actually had very, very different inflammatory patterns. We had some patients that had no inflammation. This is the same pattern we're seeing. And then we had other patients that had lots of inflammation. And so what that tells us is how we need to do a better job treating. If I treat this patient with any immunosuppressant category, because there's all these different markers of inflammation, they're gonna feel better and do better. If I treat this patient with an immunosuppressant, they're gonna feel bad. They're gonna have side effects from this drug, and they may have no benefit. And what we need to do every visit is treat every patient as an individual and move their individual care forward. So as a rheumatologist, how do I best do this? So I'm gonna give you a couple of research slides to mostly give a shout out for my Utah patients that participated in these research studies. What you gave to us mattered and helped us move the field forward. So one of the very first studies I did was I wanted to try to understand the genetic risk factors for scleroderma. So if we kind of understand, if you're born with your genes and then something triggers a disease, what are those genes for scleroderma, and how do we sort of understand how to identify patients better? So we looked in the Utah population database. And so what Utah population database allows you to do is you look for a diagnosis. So in our case, we're looking for scleroderma. And you take those scleroderma families and you compare them to pedigrees that look exactly the same but don't have any scleroderma. And then you can look for different traits or diagnostic codes in the families with scleroderma and the families without scleroderma, and try to understand sort of comparable heterability. So when we did this back in 2010, 2009, 2010, we found there were over 1,000 patients with scleroderma. And when we compared those to families without any scleroderma, we found it was very interesting. Raynauds phenomenon was 6 times more likely in a first-degree relative and 2 times likely in a second-degree relative. We looked at autoimmunity, so we looked at codes for lupus and rheumatoid arthritis and inflammatory myositis and all these diseases that a rheumatologist would take care of. We similarly saw there's some genetic risk to autoimmunity, but less in those first-degree relatives than that Raynauds phenomenon. And when we looked at interstitial lung disease, interestingly, there was less genetic load, so less times likely, but it extended out further to the third-degree relative. So we took that to mean if you're gonna look at genetic load for a risk of scleroderma, the Raynauds phenomenon was a really important question for a patient for trying to understand if my child or my sibling has Raynauds phenomenon, should this patient be assessed? And I took this to change my practice, and yes, they should. And what we should do is we should look at the bases of those fingers for capillaroscopy and try to understand, do they have features of scleroderma? The next thing we said, okay, is let's take patients with just Raynauds phenomenon, and then let's take patients with scleroderma and compare those different skin biopsy samples. And anybody, I always show my arm. I have 40 different scars on my arm because I had to work out how to do this right. And I was not gonna ever experiment on a patient. So we experimented on ourselves, and we figured out how to look with using a whole field digital microscope to understand or train it to look at, this is a scleroderma patient and this is a Raynauds patient. What's the difference here? And what we found, kind of interesting things, even if someone had normal, I pinched the skin and it's normal, a scleroderma patient universally had endothelial or blood vessel lining cells abnormalities. So they were swollen and they were puffy and they had these signs. So the staining told us that was under oxidative stress. So that blood vessel was really under stress. We did not see this in our healthy controls or our Raynauds phenomenon. And then what we were really interested in is in each of these blood vessels, we saw these mast cells, which are allergic cells, and swelling all around those Scleroderma specimens. And what was interesting, it wasn't an abnormal number. It wasn't like there was all the blood vessels were recruiting masses of different immune cells. They were normal numbers, just their location, they were all up against that blood vessel. And so what we said is if these blood vessels are universally abnormal in Scleroderma and they're under oxidative stress, meaning those blood vessels are sort of sending out help me signals, and allergic cells are kind of coming around that cell, how do we then take that information and try to come up with treatment strategies that make sense? So this really comes back to the clinic. I absolutely love being a clinician. I love the lab. I love trying to understand science, but my joy in life comes from knowing my patients and being a part of their lives. I think it is a blessing and a gift to be a physician. And my focus has always been, when I have a patient come to clinic, how can I make them better? And what I was really interested in was these ulcers that occur are really very, very painful. So we could spend time looking at cells in a petri dish, or we can really try to think, how does that concept apply to our patients? So the first thing we said, well, we've got to figure out, we've got patients that get ulcers because they have trauma. We have patients that form calcium deposits around the blood vessels trying to heal them. And then we have patients that have ischemia reperfusion injury, which that means is that's what a heart attack is. You don't get blood flow and then you do get blood flow. And what that seemed to do is cause these pitting scars. So not getting blood flow was triggering scarring. What can we do to kind of prevent this ulceration occurring around the spectrum of Raynaud severity? And I thank all the patients that provided these images, and they signed the consents to allow me to do it. But these are real patients of mine in clinic saying, what are you going to do to help me feel better? And so what I said was, okay, I need to do a better job understanding what are these universal abnormalities in our patients that have Raynauds and Scleroderma, and how are those different from the patients that don't get Scleroderma? And so what we decided to do, and I got funding from the government and a lot of funding from the Veterans Affairs Medical Center, which I'm very grateful for. They paid us to study Scleroderma in the university setting, in addition to the VA, to understand how do patient-reported outcomes, nail fold capillaroscopy, flow-meted dilation. I'm sure a lot of my patients are shaking their heads like, oh, I remember these studies, where we measure the brachial artery response to vascular occlusion, digital thermal monitoring, where we occlude the cuff and we measure temperature rebound, and sublingual capillaroscopy, where we put this under the tongue. How do these vascular measures over time correlate with how patients are feeling on the patient-reported outcomes and treatments? Well, the key there, I will say, with clinical capillaroscopy is it is just a diagnostic skill. So we do it once at diagnosis. You can use a dermatoscope and have a capillaroscopy pattern. You can do nail full video capillaroscopy. And when I first started, we actually didn't have this at all available in the United States. So it just wasn't, we didn't have the equipment. So I put a lot of effort. Some people may remember Dr. Mislav Radic. He came in from Croatia. He was a Fulbright fellow at the University of Utah, and he was helping me bring a curriculum to the US so we can do better at diagnosis, so we can get the nail fold pictures in, we can quantify them, and really move forward with diagnosis. But for my patients, diagnostic strategies are not what I'm really looking for. I want preventative, right? So it's one thing to make a diagnosis, and we do need to move the education and curriculum forward so the US doctors make better use of diagnostic tools and make more diagnosis of scleroderma, that's for sure. But I don't just want structural. I don't want a snapshot picture and say, this patient has scleroderma. I want functional information. I want to know, if I give a treatment, is my patient getting better? And so what we really did is said, okay, if we have patients that have early, sort of mid-range and late disease, how do we best understand blood flow? So blood's going through these endothelial cells. We've got this glycocalyx. We've got these sugar cells that sit there on the top. We know that when this transduction of blood flow doesn't occur, these pericytes jump off and become myofibroblasts, and they start laying down scar tissue and start constricting the blood vessel and causing lots of harm. And as I told you, we had some really good information that all of these medications that we were using for pulmonary hypertension seem to halt that process. So what can we do to better understand shear stress to vascular transition in our patients over time? And how can we really answer the question, do vascular-based therapies actually prevent scleroderma progression? And that's sort of novel, right? We think of immune suppression, treating those myofibroblasts that are laying down scar tissue. We think of antifibrotics. These are the medications we treat scleroderma with. Well, are vascular-based therapies actually prevention? And so what we said is, okay, we've got lots of different molecular path targets that we can use. How do we then, standard of care, treat our patients with these different oral, intravenous, subcutaneous, inhaled therapies? How do we use all these therapies and understand over time their effect in prevention of complications? And that's a hard concept, right? Preventing a complication. Well, how do you know if you've prevented a complication until we in medicine more commonly think we wait for a complication and then we try to make it better. And so I was very passionate about, like, I'm totally fine if none of my patients ever get sick. I want to treat them with the very best possible therapies, give them access to these different treatments. But one of the things when I'm talking about treatments, I always like to sort of back up and say, one of the things I think we always need to stop and say, well, are we doing this to the patient? So there's a lot of treatments, particularly our ADHD medications that we use, that actually can make Raynauds worse, can make capillaroscopy worse. And so one of the things I think it's really important to sort of think through are you taking a therapy or are you taking a supplement that potentially may make the disease worse? And I like this slide for that point. I have lots of patients ask me about supplements, and I kind of say, well, if they're not studied, we don't know, but there are some that we do think cause vascular stress, and those are not good for scleroderma. So I'm going to very briefly then go through the results of all of the studies that I won't go through all of the studies, but kind of highlight some of the key teaching points we learned from the studies we did to try to understand Raynauds severity and activity in progression. And so what we did, and again, a big thank you to the folks that went over to the VA Vascular Research Lab, is the Vascular Research Lab controls patients' vascular variables, which that means is and if anyone participating in these studies, they call you and ask you, where are you with your menstrual cycle? Okay, come in today. So there's like a really good process for trying to understand what is the state of your vasculature today. And then we can do that flow meter dilation, where we occlude the cuff and measure blood flow. We can have patients exercise, and that makes the small muscles kind of steal oxygen from the blood vessel. How does the body compensate for that? We can do pharmacological interventions. And then we can do passive movement, where the patient just sort of sits there and we're moving the leg and seeing how blood flow goes. And what this is different, so that the nail fold video capillaroscopy gives you a snapshot in time. This can be repeated over time to say, I give an intervention for your Raynauds, and now how is your blood vessel responding? Does it flow better? Does it work better? Does it respond to stress better? And so when we did the first study, one of the things that and I know I'm going to show data slides, but I'm going to just kind of talk through what the kind of take-home message is. So the first study, we did this back in like 2015, is we took healthy controls and sex-matched sex and age matched scleroderma patients to those healthy controls. And we basically take the cuff, we occlude it, and then you release the cuff and you measure how well the blood vessel dilates and how much blood flow gets through the blood vessel. And we do this snapshot in time, we found that something really interesting. The first is that our scleroderma patients were different than our healthy controls, but more importantly, in red here are our patients with digital ulcers. The green here is patients with digital pits, and the yellow is a patient with Raynauds that had never had a vascular complication. And what we see just in a snapshot in time, these different markers of blood flow and how they respond to that cuff being occluded and how the blood vessel changes in size after occlusion was very different within that scleroderma subset. And so you might say, well, okay, how, that's a snapshot in time. Should we be doing this every visit? And so we asked that question, and we took patients that had 70 patients at baseline, and we compared patients that developed a digital ulcer versus patients that did not develop an ulcer. And this was actually pretty fascinating because it showed, I think for the first time, at least in my clinical practice, that we cannot be doing placebo-controlled trials. So up until this time, when we were doing digital ulcer trials, patients either got nothing or a placebo, or they got the vascular intervention. And the thought process behind that was, well, they failed the calcium channel blockers and we didn't have access to a lot of other vascular therapies at that time frame. Well, if they've already failed this drug, then they failed it. But what this study showed is a snapshot in time, as we repeated this experience, a snapshot in time, if someone has low blood flow to their fingers, they're not vasodilating well, they're gonna get an ulcer. But in the patients that developed an ulcer, they had this funny response to vessel shear. So remember I showed you those sugar substrates at the vessel, the luminal side of the blood vessel. So if that signaling is not working super well, then how do we make that blood vessel lining better? And that was interesting because all of our blood vessel medications work to relax the smooth muscle, and we hadn't been yet targeting that vascular health. So this was a really important, I believe, finding that said, first of all, every patient should be on a vasodilator if they have active Raynauds phenomenon. There's less data, so that's where if you don't really have active Raynauds phenomenon, you weren't included in the study. So I have to say this is only for patients that have Raynauds that's bothering them. Their patient report outcome said, yeah, this is bothering me. But those patients, we need to be treating really aggressively with vasodilators because it makes a difference. And so again, digital ulcers are occurring if we're not getting good blood flow, and we need to understand how that shear stress against the blood vessel wall is occurring. So then we said, okay, well, let's have the patient just come in and totally relax and try to understand, I told you oxidative stress. We saw that marker on all those biopsies. What is it nitric oxide? Because we could really do some nice targeting of that molecule. And so there's this, the way we measure that is just have the patient come in and measure blood flow by moving the leg. Patient does nothing, is relaxed. This was really interesting because when we measured the leg blood flow controls, you start cranking on the leg, they're vasodilating, there's good blood flow. Our scleroderma patients, not vasodilating as well, so significantly not getting blood flow recruited like the healthy controls, but really where that scleroderma signal came, like when you look at this whole group that's different, it was the patients with digital ulcers that was driving that scleroderma signal. And so that's when I say subset of cures. Trying to understand what patients would benefit most from interventions, we really need to think about scleroderma not as a lump sum of patients, but what's making these patients different. And so we really saw that those patients with digital ulcers were not vasodilating really at all. And then furthermore, when we're looking at markers in the bloodstream of oxidative damage and antioxidant damage or capacity, we're seeing a significant difference in those scleroderma patients. So what does that mean? Well, how do we improve antioxidant damage? Exercise, healthy diet. So we really shifted our thinking on how do we get our patients better blood flow. So healthy diet and exercise is really an important part of that cornerstone of health. But then I also kind of scratched my head and I said, okay, I'm taking this back to the clinic. I'm vasodilating, patients are exercising, they're eating healthy, but they're still getting these really pesky ulcers despite my best efforts of trying to get good blood flow. And so I thought through, well, do I need to get patients into wound care? Do we need to remove this devitalized tissue? Is there infection present? That's kind of what we do as rheumatologists. We're kind of good at those things. But then I took it to a step further. I said, well, maybe if we could get better moisture in the wound and we could promote healing, maybe we could do a better job there. And so what we brought to the clinic was these amniotic membrane dressings that had all these growth factors, all these vascular growth factors. They're sterile. They take the amnion from a C-section, they put them in regenerative medicine, they sterilize them. And we really saw quite miraculous healing. And this was one of the most exciting times in my life, because I was like, this is good medicine, and I was able to get a lot of these these donated for free, because I'd walk over and I'd get the bandages, and it was really a life-changing experience to say, we found something, we can learn from it, reduce oxidative damage, promote vascular healing, and get a good outcome. And this is not suppressing the immune system. This is not antifibrotics. This is pure base, like try to get the blood vessels to work better. And so we found that this was effective for pain relief and skin healing, and we were really very excited. The other thing, though, I want to highlight, and keep an eye on my time because I want to leave time for questions. But I also, what we did, you all might remember, we had a visiting professor come. I want to say this is maybe 2016, and he came and spoke at our local vascular, our local Scleroderma Foundation. He was from England, and he talked about Raynauds. And he was visiting because I was trying to help him develop a patient-reported outcome that better captured Raynauds. And so he was on a visiting bursary fellowship. Came out and he talked about all these great treatments in England that they use for Raynauds. And every patient kind of looked at me and was like, well, we don't use that. And it was because we didn't have access to it. I didn't have IVI laparoscopy. It was all experimental in the US. And the reason it was experimental, and the reason I hosted him out there, and the reason I was really trying to get him to help us as a community in the US, is we did not have outcome measures to allow us to get drugs through the FDA. So you can only get a drug through the FDA if it helps patients feel, function, or survival. And the way we were doing Raynauds and digital ulcer trials were completely wrong. We were taking patients that sort of had end-stage vascular damage, like where the amnion would have helped them tremendously, but if you give an oral drug, it's not getting to the ulcer. And so patients were being put into clinical trials in the US, and the drugs we knew worked, but they couldn't get through the FDA, and the reason we didn't have a good patient-reported outcome. So many of you participated, and this study, of course, started in, I think we enrolled our first patient maybe December 2019, and you're all thinking, oh, that was really horrible timing for starting an inpatient questionnaire. And right before COVID hit, we were able to enroll enough patients in this patient-reported outcome study to really get this approved. So a big shout out, a big thank you. Your time, your attention to detail made a difference. And this was recently published this past year, and saying we finally have a questionnaire that the FDA will allow us to use to get drugs approved for Raynauds phenomenon. The other thing that we're doing at Vanderbilt here is actually looking, so they have video monitoring where they just put this is much better than skin biopsies. They put this video microscope up to the skin, and they can actually measure cells that are inflammatory going through the blood vessel. So I'm finally to the point where I'm really trying to dissect through, is it the immune system or is it the blood vessel? Are you born with a blood vessel that doesn't want to act right? Or is it the immune system that's attacking that blood vessel and making it not act right? And so there's been a lot of focus in my research to try to understand the role of the immune system in Raynauds. Very lastly, the last tool that I just wanted to put out there, because many patients participated in, was the sublingual capillaroscopy that we did. And again, we really appreciate patients doing this study. We put the probe under the tongue, and we actually measure that glycocalyx as an estimate of how well the blood vessel's functioning. And so that sublingual tool allows us to functionally quantify how well blood vessels are working. And that's better, again, than this nail fold, which is just kind of a snapshot in time, looks for structural damage. And we're really interested in understanding, what does blood vessel health look like and how do we measure it? And we essentially showed that it's important to look at these tiny vessels in scleroderma. They're abnormal at all levels compared to controls. I back you up to remember, we're only looking at huge vessels when we're doing echocardiograms, and we, kind of our standard of care, these really big blood vessels. But now we have the ability to look at these micro vessels and how they change over time. And we were able to quantify this vasculopathy and correlate it to symptom questionnaires. And we really found that our patients that have more reflux and more constipation have worse vascular measures of health. And to me, that was really like career changing. Here we go. We said, we don't know what causes GI disease in scleroderma. It happens. We know patients with digital ulcers have more GI tract symptoms. We've always thought, well, maybe that's nutritional. We're finally moving the disease forward and trying to understand, Well, actually, it's the vessel health of the gut that's really causing probably changes that are causing symptoms. So how do we target GI health? Well, I'm going to go ahead and conclude here to show you that why the research that brought me to Vanderbilt. So this is kind of where I had gotten at the University of Utah, and then I got this major grant. The reason I got this major grant was I said, okay, we need to unravel GI tract in scleroderma. And there was a study that had been done by Italians that said, when we do full thickness biopsies of gastric biopsies in scleroderma patients and healthy controls, we're seeing that the scleroderma patients have these cells that are really separated from the blood microvessels. So that the blood microvessels are separating out from these nitric oxide cells. And so this is one of those, again, aha moments. Well, if you look at where those interstitial cells of Cajal live, they live in the esophagus in a deeper level. They live in the antrum of the stomach, right up against the wall. Well, what is the most common vascular abnormality we see in scleroderma when someone has a scope? It's not the esophagus. We don't have a great way. It's deep. The esophagus may look sort of patulous, and we get an idea it's not functioning. What we see in the gastric antrum or the colon during colonoscopies is gave or angiodysplasias. And so to me, if we know this exists, we don't know why it occurs, we don't understand this, how can we take this observation and move it forward to prevent vascular damage? So instead of us doing questionnaires and being like, oh my goodness, your GI tract score is horrible, I'm going to refer you to a gastroenterologist who's going to do all these invasive things to tell you your esophagus doesn't work well and your colon's not working well. What about prevention? What about like making the GI tract better or doing an improved job in understanding improve vascular health? And so I did this study called computational molecular phenotyping. We take biopsies, we process them, and each cell gets a signal for which different molecule is signaling. And I didn't have a lot of money to do this pilot, so I looked at a patient with a topoisomerase antibody, less than 2 years disease duration, someone with an anti-centromere, medium disease duration at 5 years, and someone with an RNA polymerase antibody at 10 years disease. And I said, when I look at these scleroderma patients, I look at healthy controls, what do I see? And of interest, the early diffuse scleroderma patient had every single metabolite was active. All these stress signals were going off. When we look at later disease, we saw that arginine was the one molecular signal, which is the rate limiting substrate for making nitric oxide, making antioxidants, was abnormal. So getting to this, sort of how do we link Raynauds and GI tract together, and how do we try to understand it? I said, well, gosh, if ischemia reperfusion makes blood vessels leak, makes cells die, makes them act funny, send out new chemical signals, and activates autoimmunity and immune reaction, how do we model ischemia reperfusion without sticking up or punch biopsying someone's arm every time they come to clinic? And how do we get tissue and understand this? Well, then I became interested, and I started taking classes on how to generate inducible pluripotential stem cells. So this is where we take your blood cells and we can reinduce them and make them into endothelial cells. So we did this in scleroderma patients, and we did this in healthy controls. And sure enough, this is baseline, I drew up some blood from you. I looked at scleroderma and I looked at a healthy control. We see oxidative stress genes are different between healthy and scleroderma patients. So if scleroderma inducible pluripotential stem cells, we can get this from your bloodstream, doesn't hurt you, doesn't cause you to have repeated biopsies or repeated measures, how should we best test them? So this is where I get this system, I take this class, we learn how to make these cells, and then my grant gets approved. I get money to do this project, and the University of Utah said, you can't do this project because we need you, we're not gonna make scleroderma a priority. I call Vanderbilt, I ask if their VA, if they need someone, how many days do I physically have to spend there to do this project? They said, we wanna help you do this. We think this research is important. And so what we were doing is we take these cells and we grow them on an electrode and we measure how well does the cell work. So when we start, even though those genes are different between healthy controls and the scleroderma patients, we measure them, they act exactly the same. We say, okay, that's good. Even though the genes are baseline different between a scleroderma patient and a healthy control, they are acting the same when we're measuring how they are functioning. And a p-value of less than 0.5 means it's significant. You can see scleroderma and healthy control, exactly the same. They are working great. Now, though, we start to do some funny things to them. So we wound them. So this is an electrical wound. And all of a sudden, scleroderma cells start moving like crazy. We also put inflammation on them. Scleroderma patients become very, very leaky. So back to kind of that concept of Raynauds, we have a patient that has Raynauds and then something triggers it. Is it an infection? Or is it something inflammatory? Is it the vasculature getting injured and they're moving and they're causing scarring differently? We really believed we had a model here that could help us understand vasculopathy. So, how do we bring this back to the clinic? I like to give a shout out for Rachel Lando. She was the first person that taught me in clinic I wasn't doing enough to encourage exercise. And this was years ago. And I give a shout out if you haven't seen her patient care movement website. I think it's very valuable. I really believe that getting vasculature to vasodilate in response to exercise and movement is key. For pulmonary, if you have a diagnosis of interstitial lung disease, ask about pulmonary rehab. You may qualify for that. For gastroenterology, I really turned to nutrition. And this is tricky. It's a whole talk for another day, but nutrition is different for every patient. But working with a nutritionist for healthy diet for you, getting nutrients in your immune system, we have shown makes your blood vessels function better, makes your Raynauds better. It's subtle. It's not like you're going to wake up and give me a hug and say, that was so much better. But it's worth the effort of trying to do a healthy diet. And then I really can't give enough shout outs to wound care, occupational therapy. Trying to get blood flow to the hands and protect those wounds is incredibly valuable and important. And so I think a rheumatologist needs a robust care team. Lastly, I will end here on how I started with just a small clinical program. My focus was I wanted to diagnose early. I wanted to be good and proactive with screening and monitoring and giving good therapeutic interventions. My goal was preventing disease progression. But I really highlight that collaborative research is key, regardless of how long you've had scleroderma. So the CONQUER, the Collaborative National Quality Efficacy Registry, we started, and actually the database for this national registry, which is internationally renowned, is in Salt Lake City. We started this, and what we said is we're gonna work with all the scleroderma centers across the US, and we're gonna donate our time and make sure we meticulously patient phenotype and compare how patients are doing. And what that allows us to do is say, is this intervention working or not? So it's not pharmaceutical funded, it's allowing doctors to use good, clean data to help inform outcomes. And it's important to realize by doing this, we know that scleroderma patients do really well if we get patients to exercise and if we make sure that Raynauds is well controlled. So I conclude by saying, I will leave the time for us to discuss, why vascular assessment and treatment is critical. I really wanted to kind of reconcile why it seems a little scattered to think, well, she's kind of diffuse with her research. She does ulcer stuff and she does GI stuff, but it all was this understanding of how blood vessels progress and cause damage, and can we come up with targeted treatments to improve that? And then just kind of end by saying, I think multidisciplinary collaboration is really very valuable. Our community is better because you're in it. Everybody's voice really matters. I've learned so much from my patients. Every motivation, every facet of my research has been because someone has asked me a good question and asked me to do better for their care. And so I thank you. I give a shout out, of course, to all of our scleroderma patients and care and advocates, and I give a big shout out to the run. I personally can't be there because my son is graduating from high school at that exact time. So I can't be there, and my family usually who shows up if I'm not physically in town won't be there, but I'm there in spirit, and I certainly will donate. Carolyn, so send me the link. And then again, all the people that fund us and all the people that do all the basic science work, very, very grateful for that. And I will stop sharing